Today's program, first there will be a case presentation by Dr. Shumanta Chatterjee. May I request him to share the screen? You are going to share the screen, or?
Yes, yes. I will share the screen.
Please.
Good evening, everybody, and it's I'm kind of honored to share the stage with all stalwarts, and we are very thankful to Dr. Guha for this platform, creating this platform and having some academic feast every alternate week.
There was launch meeting.
So my slide is visible?
Yeah.
Yes, it's visible.
Okay. So one 67-year-old lady presented with shortness of breath for the last 2 months. Initially, it was only on exertion, but now it is gradually progressing for the last 2 months. Even on rest, it is she is having respiratory distress for last 7 to 10 days. And there is a recent drop in saturation. Earlier it was 95, 96, but now it is around 85 to 90% saturation at room air. And she has to use oxygen concentrator at home to relieve this shortness of breath and desaturation. There was a swelling of body, especially feet, for the last 2 weeks. Actually, she is a mother of one colleague, that is one batch, 1 year senior to me in Medical College, Kolkata. Everybody knows him, Dr. Anand. He is DM cardiologist, DM hepatologist from CMC fellow. He stays in Rishikesh AIMS, and his mother was diagnosed to have CLD, chronic liver disease cirrhosis, incidentally when she went to Rishikesh 10 months back, and she was having some gastritis issue, and then he put Dr. Anand put an endoscopy, and to his surprise, there was grade 2 and grade 3 varices. Then all investigations were done, and the patient was diagnosed to have cirrhosis, CLD compensated, and it was around 1 year back. She had a history of having COVID in Kolkata 5 months back, but it was a mild one. She had to be hospitalized then. Chest X-ray was done, and HSCT thorax was done. That was neither critical, just an oxygen was given then, and remdesivir was given. That time also she was admitted in Amri hospital. I visited her that time. There was nothing significant was there. HSCT score was around 4/15 that time. For the last 5 months, gradually 5 months, she was okayish kind of thing. For the last 2 to 3 months, she is having respiratory distress, gradually progressing now in NOH class 2, NOH class 3 now, and they found that she is having a drop in SpO2, because in now COVID, everybody is having this pulse oximeter in home. For the last 2 to 3 weeks, she is having desaturation around 85, 90. It's not that she is panting all the time, and oxygen concentrator was at home. At night specifically, she used that oxygen concentrator around 2 liters to 3 liters oxygen. She is maintaining around more than 95% saturation. This is the case scenario. Right now, that point of time, she didn't have any fever, cough, hemoptysis, chest pain, palpitation, syncope, sweating, abdominal pain, abdominal distension, frothy urine, decreased urinary push, skin rash, or joint pain. There was fever 5 months back when she was diagnosed to have COVID. So before this admission, just 1 week back, Dr. Anand called me up from Rishikesh and told that she is having this drop in oxygen saturation. Do one ECG and echocardiography, any cardiac thing is going on, because she is having respiratory distress and mild swelling of feet. At that time, I did an echocardiography. A patient came, saturation was around 85%, 88%, this kind of thing. I did echocardiography, and there was mild dilatation of right atrium and right ventricle. Pulmonary artery pressure is around 55, PASP and PAMP around 35 to 40. And there is a tear. The tear is not that much, mild to moderate tear is there. Ejection fraction was good. There is LVH is there around 20, around 12 is a ISD and PWD. And I mean, that time she was stamped to have pulmonary arterial hypertension. I thought it is a sequelae of COVID, and but to my surprise, that time 5 months back during COVID, her lung is not bad, was not bad, and PA and aorta ratio is good. That time there was no PH. Probably there was no PH at that time, because at that time she didn't undergo any echocardiography. She was having type 2 diabetes mellitus for the last 25 years, hypertension for the last 25 years, having dyslipidemia, obese, BMI is around 33. She was on metformin, insulin, losartan, carvedilol, atorvastatin, oral iron, and cobalamin. Pressure and sugar both was controlled. There is a thing 7 months back, symptoms gastritis. Incidentally, he did an upper GI endoscopy. Esophageal varices was there, diagnosed to have having chronic liver disease, cirrhosis, compensated. He had vaccinated with 2 doses of Covishield, last one taken in May. This is around October. This admission is around October. 5 months back, she was admitted with complaints of generalized weakness and shortness of breath on day of admission. HST thorax features indicating COVID-19 infection. CT severity score was 3/40, CORADS 6. Given remdesivir and steroids for 5 days, symptom improves and discharge after a week. So this is the chest X-ray, and this is the CT.
The pulmonary arteries look okay at that time, no?
Yeah.
The size and etc. and even the vasculature.
So at that time there was no echocardiography. We cannot say certainly there was no pulmonary arterial hypertension that time, but probably there was no. I mean, not at least no critical or significant pH was there at that time. Then. So on admission, pulse rate was 98 per minute, blood pressure was 130/90, respiratory rate is 20, SpO2 is 88. In room air, 99 to 100% with 2 liters of oxygen via nasal cannula. She was afebrile. Pallor was there, bipetal unbeating edema was there, clubbing was there, at least grade 2 clubbing was there, JVP raised, just bilateral vesicular vexoma was there. There was no crepitations. S1 normal, P2 was loud and split. Saturation similar in supine and sitting. Per abdomen, I mean soft, no organoid is there, no free fluid. Nervous system, no focal neurodeficit was there. This is the clubbing. Two blood tests were there. One during the COVID and one during the October, the next admission. There is nothing contributory at that time, and NT-proBNP both time is within normal limit. 1 week before admission, she was hypoxic. SpO2 was at 88% in room air. Echo study was done. This is the echo. Here we can see tricuspid valve. Ignore the tricuspid valve is normal, not normal. There was a tear is there. Moderate pulmonary hypertension with a PASP around 60 and PAMP is around 38. Pulmonary artery is dilated. RARV is mildly dilated. TAPC is good. There was no RV dysfunction. LV is good. So post admission, she was starting on oral diuretics. Beta blockers were discontinued and her home medications were continued. D-dimer was high. To evaluate the cause of this pulmonary hypertension and D-dimer, high D-dimer, opinion of pulmonologists were taken and medicine specialists were taken. plan to do a CT pulmonary angiography to rule out any thrombus in subsegmental pulmonary artery that may happen during the COVID time and now producing this pulmonary hypertension. Pulmonary function test plus DLCO to rule out airway disease. Sleep study to rule out any etiology. We are missing this obstructive sleep apnea is there, and that is the reason for this pulmonary hypertension. And Holter monitoring for picking up any paroxysmal electric fibrillation is there. For that reason, she is desaturating time to time, this kind of thing. ABG was done, resting ABG, SpO2 is around 87%, and this A minus A, this gradient is around 12 or 13 kind of thing. Past cell was there. There was UTI, though CS was negative. Basically, she was complaining that she is having some irritation in urinary tract. That's why urine culture was given. Oral levothyroxine was started. CT pulmonary angiogram, no evidence of pulmonary thrombus. Evidence of pulmonary hypertension is there. This time PA is more than aorta, and there is a there is evidence that patient is having pulmonary hypertension, but the lung is clear, subsegmental, and branches of pulmonary tree is good. There is no evidence of thrombosis. Airway disease, there is not much airway disease or ILD or parenchymal disorder excluded. This is the Holter report. There is no AFib. This is the sleep study. Result is 2. AHI is 2. No obstructive sleep apnea. This is PFT. DLC could not be done because she was having respiratory distress that day. PFT is not absolutely normal, but this slight deviation from mean, and it was not thought to be responsible for this PH because deviation is not significant. Serology HIV was negative. There was no hypothyroidism. CAG was done because she can have some left heart disease in the form of coronary disease. There was nothing. Catheterization was done. Dr. Anand didn't consent for a vasoreactivity test or right heart catheterization. He was telling that there is no extra advantage of doing that thing. You will not give calcium channel blocker in this patient because he is having decompensated chronic liver disease, and we know that what is a without any liver transplantation, patient will not survive that much. So we will not give any calcium channel blocker while doing a right heart catheterization unnecessarily. She is having some discomfort and some problem in doing right heart catheterization. So LVEDP was measured that time. It was 13. MPEP was 38. So this is a pre-capillary pH that is stamped. And a diagnosis was given that she is having portopulmonary hypertension and mild HPS. So the thing is that we have done a bubble contrast echocardiography also to rule out HPS. Bubble contrast was negative. I myself did the bubble contrast echocardiography, and it was negative. So patient is having portal hypertension. Patient is having pulmonary hypertension. No other diagnosis. No other. Possible etiology was made. That's why this portopulmonary hypertension was. Diagnosis was kept that this is a portopulmonary hypertension because by definition, portopulmonary hypertension means patient is having pulmonary hypertension in CLD and portal hypertension, and no other possible explanations or other possible etiologies excluded. That's why HPS we are very much in doubt that whether we are dealing with an HPS because hepatopulmonary syndrome and portopulmonary hypertension, these two etiologies are completely different. One, there is a vasodilatation in pulmonary bed, and portopulmonary there is a vasoconstriction in pulmonary bed. But many a times these two entities overlap, especially in advanced cirrhosis, and there is a constant desaturation, and this desaturation may be mild. Ideally, by definition, in HPS, saturation is below 80%. Here, the saturation is around 85 to 90%, and this bubble contrast should be positive there. But as there is a clubbing and there is this hypoxia and there is a CLD and portal hypertension, maybe we are dealing with this HPS because the sensitivity specificity of bubble contrast is not that much high. Pre-discharge, patient was started on tadalafil 10 milligram. Plan was to increase the dose to 40 milligram once in a day, and then to add ambrisentan if she could tolerate this tadalafil. And anticoagulation was not in place because one thromboembolic disorder may be excluded by CT, and second is already she is having varices. So discharge medication is this tadalafil, and the beta blocker was discontinued carvedilol because in portopulmonary hypertension you cannot give beta blocker. I mean, beta blocker was given previously because of this hypertension, and she was having CLD. That's why carvedilol was chosen because it's non-selective one. Because after this diagnosis of portopulmonary, he is having portal hypertension as well as pulmonary hypertension, that was to be discontinued, and it was discontinued. Tadalafil, and by the way, patient was symptomatically improved with diuretic, because this is the only medicine we gave that, I mean, that time of admission, diuretic, IV diuretic, and within a couple of days, patient improved, saturation improved with diuretic only. And then we shifted from Lasix injection to, torsemide oral drug. Metformin, same, insulin, same, liraglutide, same, atorvastatin, oral iron, and covalapine, the same medicines were continued, and tadalafil was extra added. And I forgot to mention here, he was on telmisartan for this hypertension. Post discharge, within 24 hours, patient again came to emergency with hypotension. Last day she patient got tadalafil for 2 days in hospital. There was no hypotension, there is nothing. Patient tolerated well, and third day patient was discharged. Fourth day patient again came back with hypotension. He was given IV fluids or antihypertensives, and tadalafil was stopped. He was discharged 12 hours later from emergency only. She felt better, saturation improved. She was started, and then Dr. Anand took her mother to Rishikesh AIMS. In train basically. Probably, this was a flight risk for her. That's why we advised not to take her through flight, take her through train. She traveled to Rishikesh, had sildenafil 20 mg once daily, then increased the dose to 20 milligram TDS. I don't know why this tadalafil was changed over to sildenafil, and she was symptomatically better within November. In December, he told that mother is symptomatically better with sildenafil only. They are planning to give ambrisentan group after 1 month or 2 months if she tolerates this well. So this is the case, sir.
Yeah, but Shumanta, many things remains unexplained.
Yes, sir.
Firstly, what is the pulmonary pressure like, systolic, diastolic? You have said the mean pulmonary artery pressure was 38.
Yes, sir.
This
And
doesn't
systolic
fall-
was 60.
This doesn't fall into the severe pulmonary hypertension category.
No, sir, it is
Okay.
not severe, it is
This is
moderate.
at best a moderate.
At best moderate.
Moderate.
Yes, sir.
That is number one. Number two, the patient had a very high D-dimer usage.
Yes, sir.
That is not related with COVID. So, was she having showers of emboli?
So if that means so that there's some evidence in
showers
city.
becomes very difficult to pick up in CT.
Yes, sir.
Unless
I
and
thought of
until you do a pulmonary CT pulmonary angio, there also very small showers becomes difficult to pick up.
a CT pulmonary angiography was done, sir. HSCT plus CT pulmonary angiography.
But it requires a certain size to be detected.
Yes, sir. Yes,
Small
sir. Definitely.
showers may escape the detection. Thirdly, during our student career, we used to give non-selective beta blockers in patients
Yes,
with
sir.
pulmonary hypertension,
Yes, sir.
particularly in the Shoumitra will vouch with me.
Yes, sir.
Yeah.
We used to give Inderal for portal hypertension.
Yes, sir.
In portal hypertension, now you say that in patients with portopulmonary hypertension, these are not indicated.
Yes, sir.
Why? That requires a little discussion. Why it is not indicated?
Yes, sir. The thing is that, sir, in CLD and portal hypertension, the beta blockers are indicated, but when and that is Inderal, propranolol.
Yeah, it is non-selective.
And non-selective beta blockers like
That is,
carvedilol.
what evidence we have is with propranolol.
দরজাটা বন্ধ করো, দেখছিও না, দরজাটা বন্ধ করো, দরজাটা বন্ধ করো। Yes, sir.
Go ahead.
Yeah.
So
The
you
thing
are
is that
giving carvedilol. That is also a non-selective one.
Yeah, sir. But whenever somebody develops portopulmonary hypertension or HPS, because in HPS, hepatopulmonary syndrome, there is a, selective dilatation of pulmonary bed. And where
I agree that
non-selective, differential dilatation of pulmonary bed. In some bed, there is a dilatation of pulmonary vasculature. In some beds, there is constriction. And the reverse is true in case of portopulmonary hypertension. In portopulmonary hypertension, pulmonary bed remains constricted, specifically constricted. In some part, there is a dilatation. So there is a mismatch of dilatation and constriction in pulmonary bed in both portopulmonary and hepatopulmonary. But hepatopulmonary mainly deals with dilatation, and portopulmonary mainly deals with constriction. So as there may be an overlap between this HPS and portopulmonary hypertension, and there is an overlap of dilatation and constriction. That's why dilators are avoided in portopulmonary and hepatopulmonary both. That's why beta blockers are not given. And also there is a doubtful role of calcium channel blocker. If there is a portopulmonary and hepatopulmonary, calcium channel blockers usually are not given because there is a mismatch between this dilatation and constriction in differential pulmonary beds. That's why there is a chance of hypotension.
Any comment?
আমার দু একটা কমেন্ট হচ্ছে। ফার্স্টলি, were there features of chronic liver disease apart from clubbing, like say spider nevus, like
Yes,
palmar erythema? Because you
palmar
see
erythema was not that much, but spider nevi was there.
Right.
Spider nevi were there.
Basically, the liver disease can affect the vasculature in two basic ways. Number one is the venous pressure, for which you get all the portal hypertension and all the other things. But that does not apply to pulmonary vein. That applies to the systemic veins.
Yes,
by
sir.
simple thing. And number two, what causes is chronic hypoxia, whatever be the reason, is the capillary dilatation and neovascularization, which is the fundamental reason for clubbing and for spider nevi, etc. So these are the two fundamental things. What is, because the venous pressure is not acting on the pulmonary bed. So is it some capillary dilatation or capillary congestion? What is happening? What is the pathology of CLD causing pulmonary hypertension?
So there's a lots of debates and lots of putative mechanism or proposed mechanism behind that thing. That is here imbalance between vasoconstrictors and vasodilators, indigenous vasoconstrictor and vasodilators in pulmonary bed, and their differential mechanism to do the vasoconstriction and dilatation in pulmonary bed rather than in other vasculatures.
So basically vague. Basically vague. Whenever you give
absolutely vague.
Whenever you give 5 reasons, that means everything is vague.
Everything is vague. Yes, sir. Everything is. There's that same inflammation, same hyperdynamic pulmonary circulation, thromboembolism, genetic predisposition, and imbalance between these things. So these are vague, but they are saying that one particular, protein, say vasopressins, say, or adrenaline or noradrenaline. This causes vasoconstriction in all vasculature except pulmonary. Except pulmonary vasculature, that their differential action between other vascular bed and pulmonary bed. This is the problem, and that gets aggravated when you develop CLD. that is the main.
Apart from the standard causes of pulmonary artery hypertension, where you have the standard algorithm, this peculiar situation, is there any role of anti-inflammatory like colchicine group of drugs? Is there any study in this particular setup?
I didn't.
Because this
came
is a very
across.
peculiar setup. CLD causing pulmonary hypertension without any gross anatomical changes.
Colchicine you cannot give in CLD. Colchicine is constantly given.
Can't give anyway. Huh?
Sumanta.
But what Shantananda was telling, this beta blocker is a bit a dilemma. Why beta blocker can't be given and why even diltiazem can't be given? I really can't fathom.
Diltiazem has a doubtful role. I mean, literatures are saying whenever somebody develops HPS, because HPS means life expectancy is less than 6 months. Severe HPS. And portopulmonary also, the role of CCB is doubtful. And they are clubbed in group 1 PH.
Now, what is the evidence that the patient had a severe HPS?
No evidence, sir. Mild, maybe mild. If there is at all
So,
any HPS,
everything is conjecture.
everything is conjectural.
And what you say it is the patient died after a few days.
Huh?
You said the patient died after a few days.
কে
No, sir.
বললো?
না না সুমন্ত বলেছিল আমাকে
না না লতা
না, না,
মানুষ মারা গেল।
এখানে না এখানে না
না না না না মানে জিনিসটা হচ্ছে স্যার পেশেন্টটা মারা গেছে এই সবে 10 দিন আগে সেই জন্যই আবার
ও।
গোটা জিনিসটা রিফার
এই এটা বলিসনি কেন সুমন্ত? তুই
এটা আমি লাস্টে বলার জন্য রেখে দিয়েছিলাম
patient died after
এটা কি ঋষিকেশে মারা গেছেন এখানে এসে?
না 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 ঘটনাটা আমার গোটা ঘটনাটা হয়েছে অক্টোবর মাসে উনি নভেম্বরে ঋষিকেশে গেছেন এবং নভেম্বর থেকে ডিসেম্বর পর্যন্ত পুরোটাই উনি সিলডেনাফেলে ছিলেন জানুয়ারিতে 23rd জানুয়ারি উনি মারা গেছেন উনি কলকাতায় এসেছিলেন অ্যারাউন্ড সেকেন্ড উইক অফ জানুয়ারি আফটার 10 days হ্যাঁ yeah
Did you measure pulmonary capillary wedge pressure during cardiac care?
no she
No,
I mean Dr. Anand
diagnose-
consent for wedge pressure measurement.
To diagnose a patient as portopulmonary hypertension, you need to measure pulmonary capillary wedge pressure first.
Yeah, sure.
If the wedge pressure
Sure.
is less than 25, then only you can say that it is portopulmonary hypertension. You have to measure pulmonary vascular resistance as well.
Definitely. But they didn't give consent for right heart catheterization. That's why it was not done. Number one, and instead we just measured the LV-EDP. It was around 12 or 13.
Yeah. Second thing, your patient was having only mild to moderate pulmonary hypertension.
Moderate
can you
pulmonary
explain the hypoxemia? How can you explain the hypoxemia on the basis of this much of pulmonary hypertension? Have you seen in your field of
I
practice?
cannot explain. That's why it is being presented here.
No, Shamanta, I think there is a shunt. Because it's a CLD, there is a arteriovenous shunt going on in the pulmonary.
Only shunt can
vasculature.
explain. Yes.
That's why
That's
the
why
DLC
I
was
have a
very
bubble
important.
contrast, but it was negative.
But you could not do the DLC. No? DLC was very important here.
Important.
DLC was very
You could have
important.
detected the shunt.
Exactly. No, I have a very basic question, Shumanto. Did you do a USG venous Doppler of the lower limbs or the pelvic veins?
Yes.
Because you said D-dimer is very high and CLD
Very
is
high
a
mean-
hypercoagulable state.
Definitely.
And as Gosar was telling, I think CTEPH, that is this chronic thromboembolic showers, pulmonary hypertension, that is a very important, differential here, because I don't think portopulmonary hypertension can have such a florid course.
Exactly.
9 months
That's why
back, she was diagnosed with a CLD that is compensated, and then 2 months back, she was admitted with COVID. Then also, she did not have any pulmonary hypertension.
Definitely.
And in these 2 months, she had developed a portopulmonary hypertension. It's unlikely. So
Siddhartha,
more
COVID has got
likely
the-
is
Probably the
showers.
spectrum, but it can happen that spectrum is, going on. The
Siddhartha,
spectrum is there. They couldn't pick up the thing because there was no echocardiography.
I think
Because,
COVID changed the scenario. And COVID is notorious to produce different kinds of thromboembolic phenomenon. The whole
Exactly.
spectrum of
CLD,
thromboembolism.
COVID, D-dimer high, everything is going in favor. So if you could have
that's
done
why she was
a
put on.
USG
Yeah.
Doppler,
One thing, Dr. Shumanto, there is a term known as portal pulmonary hypertension, hepatic pulmonary hypertension.
And that's what he was talking.
HPS has said.
Actually, a course of Eliquis or
Yes.
something, I don't know whether it was discussed, but in a case of CLD,
Definitely, sir. It was
That also I
discussed
have a
thoroughly that
question.
NOAC should be given, but as she is having florid varices and hemoglobin is
yeah,
around
okay.
9, that's why Dr. Anand said that
Ah,
NOAC cannot be
that
given.
is a very
antiplatelets
interesting
also,
question.
which is
Now, can you illuminate, can you differentiate the portal pulmonary hypertension and hepatic pulmonary hypertension in terms of clinical outcome or
Yes, sir. I mean, clinical outcome means if there is a portopulmonary hypertension, it is rather benign than hepatopulmonary hypertension, because if the patient develops hepatopulmonary, I mean, HPS, hepatopulmonary syndrome, then the life expectancy is less than 6 months. But you have to fulfill 3 criteria for that thing. Patient should have CLD, patient should be having SpO2 less than 80% in room air, and in ABG A minus A, capital A minus small a, more than 15. This gradient is most important, but it is not that, I mean, it is not there. Saturation was more than 80%. That's why there's a proposal that patient may be, I mean, we are dealing with a mild HPS maybe, and all of a sudden patient died. Just 10 days back patient died. That's why we are thinking that maybe it was an HPS. Otherwise, there was no, patient was absolutely fine for the last 2 months. Absolutely fine. The patient was better clinically for the last 2 months, and all of a sudden patient died in the morning.
Sir, I have a very interesting question, and I was just about to ask you this thing. Shuchit has reiterated the same thing. You said the oxygen therapy improved the saturation from
Yes.
85 to 98.
98, yeah.
And we were discussing about a shunt. How
Yeah,
it is
sure.
possible?
So for detection of shunt, I have done this
We
bubble
were
contrast, but it
thinking
was
about
negative.
a shunt just now. Just now we were discussing about that thing. That can
Yeah.
it be a shunt, which is but in that case, oxygen therapy is not going to help you.
Exactly. Oxygen therapy, only oxygen therapy, this much with 2 liters of oxygen and IV diuretic,
And it
patient
became
improved
98.
like
So
a
there
failure.
must be something. There must be something in the lungs itself or in the heart. If
Lungs was
by
not that
giving
much damage.
Lampic,
HSCT
I have a
was
very
done.
basic question. You mentioned that patients relative they didn't give you consent for doing CAT study, right heart study. So what was exactly the baseline of starting, indication, baseline indication of starting sildenafil? You started tadalafil, later on it was shifted to sildenafil. So how do you monitor it? What was the exact indication? I could not understand from your point. What was the indication? Because mild to moderate PH, we do not generally give this kind of medication
Yeah, sure.
until and unless you can show that there is core pulmonary sort of situation, which is very, very unlikely in this case. So why did you started pulmoprase or sildenafil? I don't understand.
And
Can you
then
explain?
these are all conjectural, because we had no proof, concrete proof, because right catheterization was not done. The only thing was done, that is ADP was around less than 15, hypoxia was there, and patient is having CLD, and varices is there, because there is, we cannot give NOAA. HSCT was done, lung is clear, but with just 2 liters of oxygen, patient improved, and with IV diuretic, patient improved. That's why we thought that
That is fine, but why did you started tadalafil? Tadalafil is something very, very specific medication for pulmonary arterial hypertension, and it is not, the points are not, enough data showing.
Definitely,
enough
there is
data.
not enough data to start any medicine, but I mean, there are some, I mean, test reports and studies are
You
there
started
in
empirically
pulmonary
to see the
hypertension.
result. Yeah. You
In
perhaps started
protocol-
empirically to see if there is any result or any.
How
Yeah,
do you
empirical
monitor the-
portopulmonary hypertension, if anything to start for, I mean, with initially, then it was sildenafil or tadalafil. The papers are
then
there.
how do you monitor the improvement, because baseline the PA pressure is not very high, so how do you monitor the therapy improvement?
Symptom SpO2 or in them. Symptoms if improve.
Symptom was
SpO2
improving with
improves.
oxygen, sir. Symptom
Yeah,
was
symptom
improving
is
with oxygen.
improving with oxygen only.
So that is nothing to do with this medication and all. So how do you
You
monitor
need
that?
to
I could not
assess
get.
the
With
pulmonary
echocardiography
function.
only, with echocardiography only,
Periodic
with
assessment,
PSP and PMP
otherwise
only.
we just cannot
No,
monitor.
what Arindam is saying is valid, that if symptoms only improve or with
only diuretic and
so why
this,
don't we keep her on diuretic?
yeah, only diuretic and oxygen.
Yeah, home
with-
oxygen and diuretic instead of doing many things.
I joined late. I
yeah.
don't know whether pulmonary CT angio was done or not.
Yes, yes.
Yes, yes, CT angiography was done and thrombus was excluded. There was no thrombus. HSCT was done. Lung parenchyma and airway is not bad.
Difficult.
I don't know. Everything is conjectural here, and use of tadalafil is also very much empirical.
Supradeep has a question. Supradeep, why don't you ask it directly? Supradeep?
Unmute, Supradeep, unmute.
Sudden death.
How will you explain sudden death in this case? By portopulmonary hypertension and with mild HPS?
That's why we are bringing this HPS into scenario. I don't know.
With
After
mild
presence of
HPS,
all these things.
is there the possibility of sudden cardiac death? Sudden death?
Yeah, HPS, the deaths are sudden usually.
Mild HPS.
What happens? Arrhythmia or what? Sudden death has only got very few limited causes of sudden death. I mean, fundamentally, there could be a lot of secondary causes, but culminating into either asystole or VF or brain hemorrhage, something like that, or sudden blockage of a valve or something. So
Usually literatures are saying that in portopulmonary hypertension patient, usually that presents with chronic liver disease, compensated, then decompensated, requiring liver transplantation and these things. And HPS, the course is stormy.
Stormy and short course.
Short course. But what is the
stormy
exact
and
mechanism
short,
of?
but before death, they will have the chance to get admitted, getting worse, getting more breathless.
Maybe some electrolytes,
jaundice,
maybe.
whatever. But maybe it is an arrhythmia ultimately at the end of the day.
Electrolytes induced arrhythmia, maybe.
Most likely. Very interesting case, but unfortunate also.
Interesting case, but we didn't get the answer. That is
That is
the main issue, because despite
And why D-dimer was high?
It was 1.85. I don't know why D-dimer was why. That's why I am very eager to give heparin.
It was
But-
persistent throughout the course.
One
of
time,
the-
just 1.8 is not that much high, but at least 10 times high. 1.8.
তুমি দেখো সুমন্ত, ওর ইনিশিয়াল কোভিডটা কিন্তু খুব হাই ছিল, 3/40 ছিল। সো দ্য ভাইরাস লোড ওয়াজ ভেরি হাই না, তাই তো? 3/40 দেখালে তো।
3/40.
হ্যাঁ, সো ইট ওয়াজ প্রিটি হেভি কোভিড। আমার মনে হচ্ছে সামথিং টু ডু উইথ কোভিড হুইচ হ্যাজ ড্যামেজ।
3/40 তো খুব বেশি নয়, এবং কোরাট 6 খুব বেশি তো নয়।
কি কাউন্ট দেখালে?
টেস্টটা খুব বেশি ছিল না, ওটা
বেশি ছিল না।
ছিল।
কোরাট 6 ছিল।
সিটি কাউন্ট।
সিটি কাউন্ট।
সিটি কাউন্ট ও সিটি কাউন্ট, সরি, আই থট দ্য
It's a very mild kind of thing, sir. Very mild. Only 4 days admission with remdesivir and steroid, patient improved and went home.
Remdesivir needed in the first admission. If COVID was not quite
That
severe.
time everybody was getting remdesivir. And everybody was getting steroid.
Anyway, that's interesting. Now, the only thing is that what is the take home in such a case if comes to any of us next? What should we have done or not done? There should be some concrete take home for some learning curve from every presentation. What is our learning curve over here?
In every patient, right heart catheterization should be done, probably. In every PH patient, right
And
heart
to
catheterization.
convince the patient party that to go for the whole thing.
Shumanta,
Yeah.
that is there. If you suspect pulmonary hypertension, you need to do a right heart cath. That has come in the guidelines also.
Yeah, that has come in the
So,
guidelines.
that is not an issue, but obviously, as you said, the patient party didn't agree for that, so that you don't have anything to do in that.
So another thing is that if we do not think in that line, that patient, right heart catheterization is for 2 spectrums. Number 1 is stamping the pressures and pulmonary artery wedge pressure and other pressures, and to see the vasoreactivity.
And at the same time, you know what type of pulmonary hypertension this is.
Yes, sir.
Pre-capillary and other things. Everything is,
Dr. Anand has given the concept for CAG. What was his reservation to give
I don't
the
know.
right
I don't
So
know.
he was having discussion with his, other colleagues over there in
the problem
cardiologist,
with
and
the doctor relative, you know. I mean, it doesn't make
he
any
is
sense.
saying that if you do not use this calcium channel blocker and vasoreactivity test, I was telling that I will not do a vasoreactivity test. I will just do the wedge pressure and stamp it. This is the exact
we need the
pressure of
diagnosis
right
before
heart.
setting. Yeah. What Arindam was saying, we need a diagnosis to go for a specific focused treatment, isn't it? Anyway,
there was a report of patients pulmonary hypertension, I mean portopulmonary hypertension, dying suddenly because of ventricular arrhythmia related to prolonged QT.
That is of course it is an arrhythmic death. I think it is an arrhythmic death. But anyway,
She had a sudden death.
Yeah, I mean,
Arrhythmic
she
death.
called me up in 3 a.m. in the morning. My mother is having some kind of discomfort, some uneasy feeling she is going through. Okay, just bring her to the hospital emergency. At 6 o'clock, she brought her to the emergency, brought dead. 3 hours.
Or maybe that 40% LAD plaque has ruptured or something. Who knows?
No, sir. No, sir. LAD plaque was absolutely fine. There is a, I mean, this curve is there. There is no plaque. I mean, eccentric plaque was there. I mean, prone to be ruptured. This is not the case. This is not the case.
It is difficult to say. It is difficult to say.
Anybody's guess.
It is anybody's guess.
Second topic. Let's go to the second topic.
Yeah, it's a very interesting case.
Very interesting case.
Very interesting case, but Shumanto, perhaps you would have benefited us by giving a little bit of input on a few issues, like you have given that proposed mechanism and other things. You said that the points of discussion, that what you think about the case, because you have seen the patient. Discussing and seeing and following a patient is totally different. You have seen the patient, what you feel was the cause of the death.
I thought, I mean, NOAC should be given. I mean, anticoagulation should be
that is
given.
Exactly.
That's what I was.
What everybody is telling.
That's what I thought. Yeah.
Everybody.
Many times I counseled him. Do give anticoagulation. Do give anticoagulation. But
you had an accidental detection of varices.
Maybe 2.5 BD. Maybe 2.5.
Did it bleed?
No. There was no bleeding. There was no bleeding. Incidentally, there was a he put
that was
this
an incidental
endoscope.
Detection of some varices.
Exactly. In this incidental detection of some varices, but
And
as
when
he is
there is a
telling
very
that varices is grade 3.
D-dimer. Well, of course, there is a risk on both the sides. It can bleed and have a massive hemorrhage and can kill the patient. On the other hand, if you don't give anticoagulants, patient can die of pulmonary thromboembolism. So either way, thank you for presenting this very interesting case. Next, let us move to the next one. Next case, next speaker is Dr. Ovik Karat. He will be speaking on HCM. Ovik, you are here.
Yes, sir. Yes, sir.
Please start sharing your screen.
Shumanta, you need to unshare your screen.
Unshare. Shumanta, you please unshare.
Yeah, thank you. I hope the slides are visible.
Yeah, slides are visible, but let me, before you start, let me acknowledge one thing. I find one of my teachers here, Anyanda, taught me. In fact, when I was in DM, Anyanda was a lecturer at SSKM Hospital, and I attended some of his classes. Thanks for joining.
Oh, thank you.
He is teacher of every teacher now. That is not a compliment. That only shows he's too old. The thing is that Ovik, I'm more scared not of Anjanda, but your number 59.
Sir, I will try my level best to stick to the time.
Please, sir.
Yes, sir.
Now, his time is 30 minutes. 59 slides he can cover. Come on.
Okay. Good evening, everyone. So the topic is hypertrophic cardiomyopathy with risk stratification management. So the flow of my talk will be based upon 3-4 case scenarios. Along with that, I would like to just briefly touch upon the various clinicopathological situations that are seen in hypertrophic cardiomyopathy with the certain mechanisms also, which will help us in better understanding of the situation. So moving on, the First case, 42-year-old non-hypertensive male with complaints of exertional dyspnea, angina, dizzy spells with a forceful apex and a systolic murmur in the left third intercostal space. ECG with a left ventricular hypertrophy, echocardiogram showing an ejection fraction 72% with a IVS and PWD 28 and 16 mm with an LVOT gradient of 60 mmHg. So it's a case of hypertrophic cardiomyopathy with obstruction. So what is HCM? It's a left ventricular hypertrophy in the absence of another cardiac, systemic or metabolic disease capable of producing the magnitude of hypertrophy evident in a given patient and for which a disease causing sarcomeric variant is identified or a genetic etiology remains unresolved. Now, the imaging diagnosis is based upon either echocardiogram or a CMR, which shows a maximal end diastolic wall thickness of more than or equal to 15 mm anywhere in the left ventricle, in the absence of another cause of hypertrophy in adults. More limited hypertrophy, like 13 to 14 mm, can be diagnostic when present in family members of a patient with HCM or in conjunction with a positive genetic test. Prevalence is almost in 1 in 500 with an equal male to female preponderance. Right ventricular involvement is seen around 10% and an autosomal dominant inheritance is seen in 60% of the patients. Broadly, it can be either with a dynamic obstruction or without obstruction. The clinical features are patients are frequently asymptomatic, commonly presenting with dyspnea, chest pain, palpitation, syncope. Symptoms are often exacerbated by stress, either in the form of exercise or a large meal intake or alcohol intake. Signs, brisk pulse, forceful apex, double or triple apical impulse, S4, systolic murmur. Now, for the diagnostic,
can you have a full screen presentation? That is a request.
Okay, just a sec. Okay.
Yeah, that's better.
So for the diagnosis purpose, the various tools are ECG, as is shown in this ECG, with a left ventricular hypertrophy, LA enlargement, deep T-wave inversions in the lateral precordial leads, suggestive of apical HCM. Also, in some patients, there can be deep Q waves in the inferior leads, mimicking often an inferior wall MI. Also, pseudo-infarction pattern can be seen in the lateral leads, and ECG can be normal in up to 6% of the patients. Now, the 24-hour for the rhythm assessment, 24-hour Holter monitoring or 48-hour Holter monitoring, which is primarily to diagnose any underlying arrhythmia in the form of atrial fibrillation, which can be present in 25% of the patients. Ventricular tachycardia, which is a SCD risk factor, and supraventricular tachyarrhythmias. Often found conduction disturbances after septal reduction surgeries. Prolonged rhythm assessment can be done in patients with paroxysmal arrhythmias in the form of ILR. There is no role of invasive EP study. Chest X-ray often reveals features of left ventricular hypertrophy, and in the image on the right-hand side shows also an ICD implanted in such a patient. Echocardiogram can be used for diagnosis and classification, for screening purposes, as well as for risk assessment and prognosis. In echocardiogram, wall thickness is very, very important thing that we need to keep in mind. More than or equal to 15 mm involving any of the left ventricular septum in adults, more than or equal to 13 millimeter in the first degree relative of hypertrophic cardiomyopathy or in a patient who is having a positive genetic testing. In children, it is more than 2 times the standard deviation above the predicted value, and LV wall dimension more than 30 mm becomes a sudden cardiac death risk. Asymmetric septal hypertrophy is also a very classical finding, with a septum is to posterior wall thickness ratio more than or equal to 1.3:1, and if the patient is also hypertensive, it is more than 1.5:1. Now, there's a very interesting, there's a very interesting diagram that has been shown in patients with, in the recent ACC 2020 guideline, that is in patient who is a suspect or in a patient who is having a family history of HCM, how to approach regarding the various diagnostic tests. If the patient is phenotype negative, after the initial diagnostic testing in the form of ECG or imaging, we need to see whether the patient hails from a family with a known pathogenic or a likely pathogenic variant. If yes, we need to see whether the patient has a family variant or not. If the patient does not have any family variant also, then further testing is generally not recommended, and we need to reassess the variant classification. If the patient is hailing from a family, and the patient has a family variant, then screening ECG and echocardiogram should be done. If the patient is phenotype positive with suggestive of hypertrophic cardiomyopathy in either the ECG or imaging or in genetic test, a complete baseline evaluation should be done with sudden cardiac death risk assessment, stress testing if symptomatic, and if LVOT obstruction is suspected. Every 1 to 2 years or with the change of symptoms, serial evaluation for the clinical status needs to be done. SCD risk evaluation needs to be done, and these can be done even sooner in the whenever the patient presents with any change in the symptoms. And it should always include a thorough clinical assessment, echocardiogram, and an Holter assessment. CMR for the SCD risk assessment should be done every 3 to 5 years, or to evaluate whenever we are suspecting any morphological changes. If the patient is asymptomatic, in every 2 to 3 years, treadmill testing or a CPET can be done for assessment of the functional status. And if the patient is symptomatic, in this situation, we need to do a stress echo if the gradient is less than 50 mmHg, or a CPET for considering advanced heart failure therapies. Now, the basic screening things that we need to do, that is screening with ECG and 2D echocardiogram in asymptomatic family members. If the patient is a pediatric age group, in children and adolescents from genotype positive families and families with early onset disease, then initiation of the screening should be done at the time of diagnosis in another family member and should be repeated every 1 to 2 years. In all other children and adolescents, initiation should again be done at the time when a family member is diagnosed, and the repetition should be done every 2 to 3 years. And if the patient is an adult patient, then again the initiation should be done at the time of HCM diagnosis, followed by ECG and echocardiogram every 3 to 5 years. And importantly, the repetition of the ECG or ecocardiogram can always be done whenever there is any change in the symptomatology of the patient. Now, regarding the left ventricular hypertrophy in HCM, again, it can be the most commonly is the basal anterior septum. In continuation with the anterior free wall is the most common location, and a diffuse symmetric hypertrophy can be seen in up to 25% of the patients. These are the various left ventricular morphology that is seen in HCM. There is sigmoid separate septum, reverse curved septum, neutral septum, which is all throughout it is thickened, and apical variant. SAM is again very important finding that is found in echocardiogram, is an image showing the systolic anterior motion and the various gradations of the systolic anterior motion of mitral valve in echocardiogram, grade 1 to grade 4, which is progressively increasing contact of the mitral leaflet with the septum, is depicted from 1 to 4. Regarding the dynamic LVOT obstruction, there is a typical dagger-shaped CW tracing with a CW Doppler gradient more than equal to 30 mm at rest or more than equal to 50 mm Hg with exercise or with Valsalva strain. It's usually present in more than in approximately 75% of the patients with HCM, and the basic two mechanisms responsible for LVOT obstruction are septal hypertrophy with narrowing of the LVOT, which produces a Venturi effect, producing a displacement of the anterior mitral leaflets anteriorly, and also an underlying anatomic alterations in mitral valve, including a longer anterior mitral leaflets, and the anterior displacement of the papillary muscle is also an important thing that need to keep in mind. Regarding the mitral regurgitation, which is found in echo, again, it can be secondary to LVOT obstruction or from the primary leaflet abnormalities. And important thing is a significant mitral regurgitation may not be evident until a provocation is done for LVOT obstruction and the SAM of the mitral valve. Primary valve abnormalities needs to be kept in mind. Now, moving on to the second case scenario, a 58-year-old non-hypertensive female, exertional dyspnea, non-specific chest pain, cardiovascular system does not have any, the patient does not have any murmur, LVH with strain on ECG, an echocardiogram again shows an asymmetric septal hypertrophy with normal LV ejection fraction without any LVOT gradient at rest. So is it an HCM without obstruction? Often in patients without resting gradients, Valsalva may show a gradient of more than equal to 50 mmHg. Even with Valsalva, if the LVOT gradient is less than 50 mmHg, or in patients who are unable to go for a Valsalva, many a times making the patient from supine to standing position also brings out a gradient. But if these maneuvers do not produce, bring out a gradient of more than 50 mmHg, then exercise stress echo may be done, which might show an LVOT gradient of more than equal to 50 mmHg. So to stamp a patient with HCM without obstruction, we need to do these things before we stamp the patient as without obstruction. The other imaging options that can be done is a contrast echo, transesophageal echocardiogram, which is especially important during surgical myectomy, CMR, and strain imaging. CMR accurately measures the left ventricular wall thickness. HCM morphology is also identified in the CMR. It sorts out the mid-cavitary obstruction with apical aneurysm from the apical hypertrophy. Right ventricular hypertrophy can be very well delineated from CMR, and it has a vital role in the mechanistic evaluation of the LVOT obstruction and the degree and mechanism of MR. And a native prolonged T1 relaxation time correlates very well with the late gadolinium enhancement and an underlying fibrosis, which is important for the risk stratification. Late gadolinium enhancement, which is basically focal areas of mid-myocardial fibrosis at the site of maximum wall thickness, again very, very important for our SCD risk assessment and stratification. And it predicts a sudden cardiac death or heart failure if the LGE is more than 20%. Further imaging modalities can be a SPECT myocardial perfusion scan with a resting perfusion abnormality coexisting with fibrosis, which is also not only a marker of sudden cardiac death, also predicts future NSVT. In cardiac CT if MRI is contraindicated, though the role of cardiac CT is very, very less in patients with HCM in comparison to CMR. Important thing we need to keep in mind are the close differentials. There is a athlete's heart, amyloidosis, Fabry's disease. And if we very well closely look into the ECG, echo, late gadolinium enhancement, as well as the CMR, we can differentiate these things from hypertrophic cardiomyopathy. The third case, it's a 25-year-old asymptomatic state level athlete whose father has diagnosed HCM. ECG and echo is normal. Should we declare him fit, or we need to do something more? Further workup, we can always advise a CMR and genetic testing, though doing a genetic testing in our setup is very, very difficult. So CMR is a very good option, along with the other investigations which I've already mentioned before. Higher T1 values than normal, then we need to keep that probably there is an underlying phenotypic expression that is coming up. And in LGE, we can find evidences of focal fibrosis. Again, we need to be very careful. Now, genetics in HCM, when the diagnosis is equivocal, more than 11 genes have been identified. One of the most commonly, the beta-myosin heavy chain, MYH7, and the myosin binding protein C. Sarcomeric gene mutation is important because it may increase the heart failure risk, which is important for the prognostic purpose. Follow-up, the first degree relative of HCM patients without phenotypic expression. If the index patient is in the 10 to 20 years age group, ECG and echo screening 1 to 2 yearly, and if it is more than 20 years up to 50 years, every 2 to 5 years. This I've already mentioned. And the patients who, though the patient is a first degree relative of HCM, if the patient does not have a phenotypic expression, usually the clinical course is benign. Case 4 is a 55-year-old male who is diabetic and smoker. Acute severe chest pain 2 days back, had a TROP-T, strongly positive TROP-T with a normal renal function, no syncope. Echocardiogram showed an hypertrophic cardiomyopathy without obstruction, though stress imaging was not done. Coronary angiogram revealed 95% stenosis in a dominant left circumflex, and a Holter run showed runs of non-sustained BT. So now this becomes a very tricky situation for us to manage. This is very, very important because we know that an underlying severe stenosis itself can be an underlying cause of a non-sustained VT. At the same time, non-sustained VT at the age of 55 years age with a background of hypertrophic cardiomyopathy again becomes an important consideration with reference to the sudden cardiac death risk assessment, prognostication, as well as management. So if we look into the myocardial ischemia, the underlying mechanisms is primarily a sort of demand supply mismatch because of significant myocardial hypertrophy. Microvascular dysfunction with an impaired coronary flow reserve is also important. Medial hypertrophy of the intramural arterioles and the reduced density are also common findings, which can also precipitate a low flow situation. Myocardial bridging is also a very important thing, but though as an etiology for myocardial ischemia is a very, very rare entity. And reports of concomitant coronary artery disease in HCM, the reports on the prevalence has been varied, but up to 20% of the adult HCM patients have been shown to have coexisting coronary artery disease. Now, if we move on to the potential complications of hypertrophic cardiomyopathy, ventricular arrhythmias, heart failure, atrial fibrillation development, all these needs risk stratification for further management. Now, we look into the SCD of ventricular arrhythmia. The high risk features are a family history of sudden death from hypertrophic cardiomyopathy. It's primarily important in patients who have this history in more than equal to one first degree relative or close relatives at less than 50 years of age. Massive left ventricular hypertrophy, as we have already described, a wall thickness of more than equal to 30 mm in any segment within the chamber by echo or CMR imaging. Consideration for this morphological marker is also given to borderline values in individual patients at the discretion of the treating cardiologist. For pediatric patients with HCM, an absolute or a Z-score threshold for wall thickness has not been established. However, a maximal wall thickness corresponding to a Z-score more than equal to 20 and a more than 10 in conjunction with other risk factors appears reasonable. Unexplained syncope, more than equal to 1 episodes of unexplained syncope episodes involving acute transient loss of consciousness without any definite attributable cause or etiology, and not attributable also to the left ventricular outflow tract obstruction, and especially when occurs within 6 months of evaluation, is very, very important with respect to increased sudden cardiac death risk. HCM with LV systolic dysfunction, a sort of burnt out stage, is also very, very important with a very high risk of sudden cardiac death. An ejection fraction of less than 50% by echo or CMR imaging. LV apical aneurysm is again a very important thing. Apical aneurysm, defined as a discrete thin-walled dyskinetic or akinetic segment of the most distal portion of the LV chamber, independent of the size, is a increased risk factor. Extensive late gadolinium enhancement, more than equal to 15% of the LV mass, is an important thing for which and though one important thing is when respect to the children, the extent of LG which is conferring risk has not been established. Non-sustained VT on ambulatory monitoring is also a high risk feature, but important thing is we need to keep in mind is one, recurrent bouts of non-sustained VT, longer bouts of non-sustained VT, faster bouts of non-sustained VT with rates more than equal to 200 beats per minute, and a VT rate that exceeds the baseline sinus rate by more than 20%. These are considered significant when we need to assess the increased risk of sudden cardiac death and the consideration for ICD. Now, one important thing is an abnormal blood pressure response to exercise stress testing. An abnormal blood pressure response to exercise is defined as a failure to increase the systolic blood pressure by at least 20 mmHg, or a drop in the systolic blood pressure during exercise of more than 20 mmHg from the peak value obtained. It is very, very important because it is very definitely associated with a poorer prognosis in these patients. So high risk subsets are the patients with LV aneurysm and a burnt out HCM, and a potential risk is a very less age less than 30 years with multiple risk factors and an LGE more than 15%. So next is assessment of the heart failure risk. The heart failure risk is in patients with HCM with LVOT obstruction, the degree of LVOT obstruction hypertrophy is important. And in patients without obstruction, the fibrosis extent of the fibrosis is important while assessment of heart failure risk of the patients. And regarding the risks of atrial fibrillation development, The higher the diastolic dysfunction, higher is the risk of atrial fibrillation development. The extent of left atrial enlargement, the left ventricular outflow gradient, the advanced age, and the higher BNP values is again directly correlates with the risk of atrial fibrillation development in these patients. Now, moving on to the management, the general measures: drug therapy, septal reduction therapies, management of heart failure, management of arrhythmias. General measures include lifestyle modifications. The important thing we need to keep in mind is a sudden intake of very large meals, and especially a very high fat content and protein content meal is an important risk for precipitation of or increase in the outflow tract obstruction. So we need to advise the patient to have small frequent meals and avoid, and also we need to ask the patient to avoid alcohol. Exercise, severe intensity or a very high intensity of exercise needs to be avoided. A mild to moderate intensity exercise can be continued. Obesity needs to be addressed, and obstructive sleep apnea needs to be again addressed. We need to strongly advise against any situation where the patient might end up in dehydration, especially very, very important in the summer season. We need to ask the patient to actively and consciously increase the intake of fluid intakes to avoid dehydration, because that again is very, very important, and vasodilators need to be avoided. Coming to the drug therapy, the most important drugs are the beta blockers, which improve the exercise tolerance. Calcium channel blockers like verapamil and diltiazem, if the beta blockers are ineffective. And in patients with in patients who are not adequately managed or the symptoms are not improving with beta blockers, disopyramide, a class 1A antiarrhythmic agent, can also be used. And mavacamten is again a drug which modulates the myosin ATPase and reduces the sarcomeric hypercontractility, can also be used. Septal reduction therapy indications: NIHA class 3 to class 4 dyspnea, or chest pain or pre-syncope or syncope, LVOT gradient either resting or provoked more than or equal to 50 mmHg, and septal thickness more than 15 mmHg are the indications for septal reduction therapy. Now, the choice of the septal reduction therapy, either alcohol septal ablation or a septal myectomy, wherein the surgeons remove 3 to 10 gram of basal septum. So alcohol septal ablation, comorbid non-cardiac conditions are there for which an septal myectomy may be contraindicated in those group of patients. In elderly patients, in patients with pre-existing right bundle branch, and in patients who have already had a prior permanent pacemaker. Septal myectomy in patients who have an primary mitral valve abnormality, or in patients who have atrial fibrillation, where we can also go ahead with the MACE procedure for AF. And if the patient is having other cardiac surgery or in the form of a CABG, in those patients septal myectomy is definitely indicated. Younger age group patients, septal myectomy is preferred, and in a septum which is higher or the greater the LV wall thickness, the septal myectomy is preferred, because that gives a more definitive septal reduction in comparison to the alcohol septal ablation, and a pre-existing left bundle branch block, again septal myectomy. Some important issues regarding septal ablation complications: complete heart block. Alcohol septal ablation, complete heart block can develop in up to 12% of the patients. Remote myocardial infarction, VT, as well as a ventricular septal defect. Now, contrast echo with injection of the contrast in the septal perforators minimizes the ethanol volume as well as the complication, and a more targeted approach can be done. Heart failure management, usually these patients have a normal or supernormal heart ejection fraction, and often in a background of elevated BNP, they have a heart failure with preserved ejection fraction. Beta blockers and calcium channel blockers are again the drugs of choice. That is a verapamil or diltiazem group. If the beta blockers are not cannot be given, minimal or no diuretics should be given. And definitely in patients with LVOT obstruction, a relief of LVOT obstruction needs to be considered. And atrial fibrillation management is another thing that we need to keep in mind with respect to heart failure. And in patients who have a burnt out phase, we need to follow the guideline directed medical management of heart failure, including the use of beta blockers, the ACE inhibitors or ARBs or ARNIs, the SGLT2 inhibitors, and other therapies in response to the heart failure with reduced ejection fraction. And in patients with an advanced heart failure, cardiac transplant evaluation is definitely something which we need to keep in mind. CRT, there is no clear benefit in patients with HCM with burnt out phase. Arrhythmia management, heart rhythm assessment, definitely ECG is recommended, as I've already mentioned. In patients with HCM, 24 to 48 hour ambulatory echocardiac ECG monitoring is recommended in the initial evaluation and as part of the periodic follow-up to identify patients who are at risk of SCD and guide the management of arrhythmias. In patients with HCM who develop palpitation or lightheadedness, an extended more than 24 hours ECG monitoring or event recording is recommended. And in first degree relatives of patients with HCM, a 12-lead ECG is recommended as a component of the screening algorithm also. Ventricular arrhythmias, the important pathophysiologic mechanism is an underlying fibrosis, monomorphic ventricular tachycardia. And also this is very, very important in patients who are in the burnt out phase with LV apical aneurysm, as well as in patients with having a mid cavitary obstruction. Treatment, again, beta blocker or antiarrhythmic drug can be done. ICD is the cornerstone of management, though it does not prevent recurrence of ventricular arrhythmias. And in patients who are having recurrent bouts of ventricular tachyarrhythmia, ablation is definitely one thing that we need to keep in mind. In patients with HCM and recurrent poorly tolerated life-threatening ventricular tachyarrhythmias refractory to maximal antiarrhythmic drug therapy and ablation, a heart transplant assessment is indicated in accordance with the current listing criteria. This is this is from the ACC 2020 HCM guideline. And in adults with HCM and symptomatic ventricular arrhythmias or recurrent ICD shocks despite beta blocker use, antiarrhythmic drug therapy listed is recommended. Amiodarone as well as dofetilide and sotalol can also be used. Now, regarding the ICD indications, in patients with HCM who are receiving an ICD, important thing is a single coil ICD leads are recommended in preference to dual coil ICD leads. Now, when and how to give an ICD? In a patient who already has a prior event, that is a patient of resuscitated sudden cardiac death, sudden cardiac arrest, ventricular fibrillation, or a sustained VT, which is hemodynamically significant and required cardioversion. If such an event has already happened, then definitely an ICD is recommended. If the patient does not have a prior event, we need to see whether the patient is at least having one of the following, that is family history of sudden cardiac death, massive LVH, unexplained syncope, apical aneurysm, and ejection fraction of less than equal to 50%. If any of the following is there, then an ICD is reasonable. And one thing that I would like to mention over here is in the pediatric age group, more than one, at least usually a 2 of the risk factors presence is needed for a recommendation of ICD in the younger age group. If the patient does not have these high risk features for sudden cardiac death, then we need to see whether non-sustained VT is there. If the patient is having a non-sustained VT, and as I've already mentioned, longer duration of non-sustained VT, a faster rate of non-sustained VT, multiple episodes of non-sustained VT, in these presence of these non-sustained VTs, again an ICD is recommended. If the patient does not have non-sustained VT on prolonged rhythm monitoring, then we can advise a CMR with LGE assessment of the extent of the fibrosis. If there is extensive fibrosis documented in CMR, an ICD may be considered as a 2B. And if still it is not there, then ICD is not indicated. Regarding atrial fibrillation, the incidence is in the tune of about 20 to 22%. Rate control with beta blocker or verapamil or diltiazem, we need to keep in mind that digitalis should be avoided. Anticoagulation, CHATS2-VAS score is not useful, and the newer oral anticoagulants, the novel oral anticoagulants are preferred over the vitamin K antagonists. Rhythm control can be attempted with amiodarone and other antiarrhythmic drugs. 1C drugs should be avoided, and especially important in patients with heart failure symptoms is important. And the other options are catheter ablation, and in patients who are planned for a septal reduction therapy, the MACE procedure can also be done. Bradyarrhythmia and pacing, complete heart block is a finding and complication of the septal reduction therapy. And a dual chamber pacemaker is indicated as a class 2B indication, and the mechanism is by reducing the LVOT obstruction by the asynchronous and paradoxical septal motion, which pulls the septum, basal septum, out of the way during contraction. Though significant benefit was not documented previously, recent studies have shown slight benefit after 3 months. Cardiac catheterization in which patients? Despite all the investigations, the patient is having unexplained dyspnea and chest pain, then cardiac catheterization can be done, and the indications are persistent dyspnea, pulmonary hypertension, and significant pulmonary congestion. To assess the volume status of the patient, to assess the patient, if the patient is having an ongoing severe chest pain, for assessment of underlying coronary artery disease, and for planning a septal ablation. And in certain patients can also be used for localization of the obstruction, the broken borough Bronwell sign, which is very classical. Now, other advanced testing in the form of CPET with a low VO2, the low peak O2 consumption, increased minute ventilation or carbon dioxide production, which indicates a ventilatory insufficiency, and endomyocardial biopsy. A significantly positive cardiopulmonary exercise testing predicts long-term heart failure mortality. Lastly, the lifestyle management. Now, what are the important things with respect to sports or activity? For most patients with hypertrophic cardiomyopathy, mild to moderate intensity recreational exercise is beneficial to improve the cardiorespiratory fitness, physical functioning, and the quality of life, and for their overall health in keeping with physical activity guidelines. But we need to strongly recommend against with heavy or severe exercise. Pregnancy for women with clinically stable HCM who wish to become pregnant, it is reasonable to advise that pregnancy is generally safe as part of a shared decision regarding potential maternal and fetal risk, and the initiation of the guideline directed therapy. And in patients with an atrial fibrillation, we all know that in patients who are on anticoagulation, we need to appropriately change the anticoagulation according to the trimester of the pregnancy. Comorbidities, the clinician should monitor and counsel the patients on prevention and treatment of the comorbid conditions that can worsen the severity of the HCM, like underlying atherosclerotic cardiovascular disease, obesity, hypertension, and sleep disordered breathing. So to conclude, since the recognition of HCM in 1958, our understanding about the condition has expanded consistently. The diagnostic and prognostication relies mainly on the echo, MRI, and the arrhythmia detection. Medical management is the mainstay of therapy, along with the scope of septal reduction therapy and ICD for prevention of the sudden cardiac death. And further advancements in the field of treatment and prevention of the conditions are awaited. Thank you.
Abhik, hello.
Hi, sir. Yes, sir.
In your case scenario 4, so you have described the case with severe obstruction of the SARC, okay? So the echo was normal. So what was the ECG in that particular patient?
So ECG did not have any, it was basically a sort of NSTEMI, we had to stamp it. Trophy. The ECG was showing features of left ventricular hypertrophy, and on echocardiogram it showed an asymmetric septal hypertrophy.
Okay,
but so ECG was non-contributory.
So it was not a case of infarction, simply a case of
no, it's
NSTEMI, right?
NSTEM, yeah.
Yeah, Joe, it was a very good presentation. Almost there is nothing left to discuss on. But one thing I'll just reiterate, presence of atrial fibrillation in hypertrophic cardiomyopathy, pretty common. Once atrial fibrillation is there in hypertrophic cardiomyopathy, the hemodynamic deterioration is very fast and very severe. Why? Because in hypertrophic cardiomyopathy, a left ventricular end diastolic pressure is already raised.
Exactly.
So the initial rapid filling phase or slow filling phase, little blood comes from left atrium. And in fact, the left atrium here contributes to 60 to 70% of the stroke volume, unlike 20 to 20%. If the left atrial contribution is disturbed because of atrial fibrillation, the patient's hemodynamics deteriorate very fast. So in left ventricular dysfunction of diastolic type or hypertrophic cardiomyopathy, we must see to it as much as possible. We want to keep the patient in sinus rhythm. And this is one condition where rhythm control is probably more important.
Exactly.
Hovik, I have a question.
Yeah.
One of my patient, a 32-year-old male patient, on rest, he didn't have any gradient, but on Valsalva, he had a gradient of 50 millimeter mercury. And he had two episodes of unexplained syncope. So does this patient qualify for an ICD?
So
on Holter, he did have just a few VPCs. So I didn't get any NSVT on the 48 hours Holter.
Okay, see, this again is a very tricky situation. Basically, the other what was the echocardiography of the patient? How thick
Echo,
was
he
the
had
wall?
IPS 17 and LVPW 13.
So your question is primarily based upon whether the patient should be advised an ICD or not, right?
Yeah, the patient
So
is a 32-year-old man. He is very
the
anxious
recent
about.
guideline that they have done, the flow chart is very, very good with respect to this pertinent question. I'll just again show it.
If I go by the flow chart, unexplained syncope in HOCM patient, he qualified for ICD.
No, again, see, if the patient is, yes, it can be done, but also I have commented one thing that in younger patients, again, a presence of two of the risk factors is better. Yeah. So if the patient is having an unexplained syncope only at the age of 32 years, ICD can be done. It's a two-way indication, but I feel presence of another risk factor is important. So what I would do is, if NSVT is also not documented on a Holter, and if the other risk factors are not there, then advice of a cardiac MRI is definitely an important thing that we can do for assessment of the fibrosis. Yeah. If the patient is having a significant fibrosis on the MRI, then probably
we can go for ICD.
We can go for an ICD. That will be a better approach, probably.
Yeah. Could I have some questions? I mean, the first question
Yes,
would be in the similar lines to what Bapadito has asked. Now, you see, when you have presented, actually you have shown us that to determine the SCD risk in a patient who has an unexplained syncope, you did mention, if you just have a look at that or the previous one, you said that, could you just go to the previous slide, which you showed? Yeah. And there you said like, no, not that one. Anyway, I'll tell you what you said. You said, if this unexplained syncope is not attributable to LV outflow tract obstruction, then that becomes an indication. Yeah, if you look at it, if it's not attributable to LVOT obstruction, it would be an indication for ICD. But how do you actually, in practical, I mean, it's in practice, how do you actually make out that it is not attributable to LVOT obstruction in a patient who has LVOT obstruction?
Exactly, it is very difficult. So in a patient, in a patient who is not having a definitive LVOT obstruction, definitely this goes out of the question. But
okay, just to interrupt,
yes,
most of the patients of hypertrophic cardiomyopathy, whom even we stamp as non-obstructive, if you do some provocation, most of them develops a significant obstruction.
Yes, sir, that I've already mentioned. Yeah.
So how can you be so sure that this is a non-obstructive one?
Sir, basically, usually if the patient is not having a very severe degree of LVOT obstruction, usually just an LVOT obstruction of about 50 or 60 mmHg, usually attributable to as a cause of syncope is very unlikely. But in certain patients where the patient is having a resting LVOT gradient of about say 70 to 80 and with mild minimal exertion also, if we can if it is going up to 110 mmHg, definitely that becomes probably a important thing that this might precipitate a syncope. But a very low grade obstruction is probably not does not usually contribute to a syncope.
Again, this is a relative thing what you are telling.
Yes, sir, definitely.
It is absolutely
because definitely
what
attributing
has asked. this is a totally relative thing, because
Exactly. Because
what
definitively
we need,
attributing the syncope to LVOT obstruction is very difficult, or
what
ruling
we
out
need
as
to
an
do is
obstructive.
whether this syncope is hemodynamic or arrhythmic. That is what we try to differentiate.
There is a test to differentiate between the two, but clinically and in practice, I find it very difficult. It's treadmill test. Once you ask the patient to go for TMT, and if he has any symptoms developing because of the severity of LVOT obstruction following exercise, that may give you some idea. But I personally believe that such test in our setup, with the patient presenting with HCM, is probably careful attention.
Could I make two quick, one
Yeah,
question
sure.
and one
Carry
comment?
on.
Well, my comment is that Ubik mentioned that for mavacamten, there is this phase 3 studies are awaited. But this is not true, because Explorer HCM study was a phase 3 study. It actually showed that mavacamten can significantly reduce the LV outflow gradient, improve symptoms, improve functional capacity, CPET, CPAT and all. So that was a very positive study and a phase 3 study. What it hasn't showed whether it would reduce mortality or sort of hospitalization, that it hasn't shown. It was not designed to look at it, but at least it was a positive result, and it was a phase 3 study. And the last question to you is, like you did mention, like during sport participation, you mentioned about the test that could be done is a genetic testing. Now, do you think the genetic testing has any role in actually, say, in advising a patient with probable HCM, who has probably maybe phenotype positive or phenotype phenotype positive, of course. If it's genotype positive, then the question doesn't arise. In a phenotype positive patient, do you think genetic testing has a role in helping you to advise the patient regarding sports participation?
Sir, in phenotype positive, probably genetic testing will not have, unless we definitely have a specific subset of genetic testing, like sarcomeric gene mutation. If it is positive, then which attributes towards a higher heart failure risk. But in patients who are having a phenotype positive for sports, I rather would more concentrate on the echocardiography findings, the CMR findings, and the exercise stress testing, which for evaluation of the sudden cardiac death risk. The genetic testing will be more important if a patient who does not have any phenotypic expression of the disease, in patients who have a family history of HCM, or in a patient who is hailing from a family with a known genetic test positive patient. So in those patients only. But again, the recommendation for the exercising again is basically depending upon the ECG, echo, CMR findings. And if it is not absolutely phenotypically, the patient is not having any expression of the disease, then probably advising against any sports activity is probably not definitively needed.
So you think a patient who has who is phenotype negative but has a strong family history of sudden cardiac death and has a family history of HCM, do you think such patient there's any utility in doing a genotyping in such patient?
Yes.
Sir, in patients who are having a very high, strong family history of sudden cardiac death, again, definitively the patient is not having any phenotypic expression, then genetic testing can be done. But again, that will be much helpful or much easier in our setup if he is already hailing from a family with a known genetic test positive. In that situation, we can definitively, in a targeted way, we can ask for a genetic testing.
Just have a look at the ESC guidelines. I can't really remember it now, but as I think it says that there is no much place for genetic testing in advising patients with probable HCM in sports participation. Have a look. Exactly. I don't really remember this well.
May I ask one question, Avik?
Yes, sir. Yes, sir.
You said that the screening with an ECG for the first degree relatives, is there any age at what age you ask for the ECG, and up to what age, if the ECG is normal, you can exclude or you release him from screening?
Sir, regarding the age of initiation of the echocardiographic screening, it is at the time of diagnosis of the family member. Whenever a family member is diagnosed with HCM, you screen all the members of the family with ECG, and even if it is a child, we need to screen with ECG. And after that, every 1 to 2 years, we need to evaluate with ECG. And
how long?
For how long, again, it is definitively not said anywhere. But the ECG and everything, if it is more till 60 years of age, after which the incidence of sudden cardiac death reduces, probably after that there is no much of a need for further.
So you advocate assessing them till 60 years of age?
Sir, in a patient who is having who is in the adult age group,
yeah,
so it's we can continue it up to 60 years of age. After that, there is no much need. But again, sir, if
but 60 years, I think it is because your risk of sudden cardiac death decreases
after
very
50.
significantly. From by
but
what
again,
age
as sir asked that from pediatric age group or a child, when to start and how long, again, sir, this specifically is not mentioned much anywhere. So depending upon the risk of sudden cardiac death, we need to think like this.
Usually it takes about 18 to 20 years to develop the ECG or echo changes. So some people say have the screening first at 18 years of age, but if there is a strong family history of very premature deaths at the age of 20, 25, 30, then perhaps you should do it in the childhood, even 10, whenever. But otherwise, say many times we see an incidental patient at the age of 60 with HCM. And maybe his grandson is about 12 years. Do you think he should have screening, or even if his son is around young, or should you wait for 18, 20 years of age for them to develop it?
I think I would advise the patient to have at least an ECG as a screening. It's a relatively cheap investigation which can be used, and so probably advising that would be better. Because though it is said that in 18 to 20 years, as you said, but with progressive generation, the phenotypic expression comes earlier, especially in the autonomic dominant inheritance patterns. So probably the ECG at least should be advised in all these patients with the family member.
Another issue is, can I ask one question?
Sure.
Yeah. So role of beta blocker, probably beta blocker is most important medicine for medical management, particularly in hypertrophic obstructive cardiomyopathy. Role of beta blocker, sir. And in also hypertrophic cardiomyopathy without obstruction, if the patient is having heart failure. Now, what exactly is the role of beta blocker in HCM patient? There is no obstruction without any heart failure. This is number one, because this is a very common practice. Most of us actually are giving beta blocker. Is there any recommendation? Is there any evidence? This is question number one. And second question, you mentioned that there is no role of CRT in hypertrophic cardiomyopathy management, but you mentioned about double chamber pacemaker. But nowadays there are option of doing physiological pacing, particularly his bundle pacing, left bundle pacing, and also there is if the patient atrial fibrillation is very common in HCM patient. Many of them are actually drug refractory. So in those cases, doing a CRT followed by AV node ablation, probably last sort of therapy, so last sort of modality of therapy. But I think there is a good role of that in particular subset of patient. And do you have any current recommendation guideline, because this is new modality of therapy, physiological pacing, left bundle pacing or his bundle pacing in this HOCM or HCM patients? Two questions.
So regarding the beta blocker, probably even if the patient does not have symptoms of heart failure, and if the patient who do not have any obstruction, still beta blocker has a role. And in certain patients, especially if a patient is having a heart rate on the slightly on the higher side, again beta blocker probably can be used, though definitive role or recommendation is very dubious. And regarding the second question that you asked, the role of, as you said, probably in these situations, it's more of a patient-to-patient or a individualized approach is better, because still I have not come across of much recommendation regarding these approaches that you said. This I have not come across. I don't know if you have come across, then I would.
A patient with patient with
CRT
hypertrophic
has some.
cardiomyopathy.
Yes, sir.
Sorry, sir.
Having features of heart failure, clinical and hemodynamics, as well as BNP, pro-BNP, anti-pro-BNP, all raised. But the patient does not have anything more other than just LVOT obstruction with more than 15% gradient. How are you going to utilize or use beta blocker in these situations? How are you going to take care of fluid overload?
So beta blockers definitely should be initiated in these patients because these are the most important drug which help in management of this subgroup of patients. Regarding the fluid overloaded status, if the patient is too much symptomatic with a very significant shortness of breath on exertion, a low dose diuretic therapy may be used, but again that has to be tailored and individualized according to the patient and the clinical response.
And regarding CRT, I think, well, CRT may be indicated in the burnt out phase when the patient's LV has dilated and all. But regarding the interesting question which Arindam asked, what about physiological pacing? I don't understand this, but the purpose of doing a dual chamber pacemaker in a patient of HCM is to induce discoordination. So if you're doing a physiological pacing here, would it not defeat the purpose?
It will be just contrary to what we expect. Yeah.
Isn't it?
That is why it's not much.
In fact, that is why you mentioned single chamber.
So in patients who is having a burnt out phase, then in those group of patients, probably the indication of CRT will be classically in the line of heart failure with reduced ejection fraction, the indications according to the classical CRT indication.
Yeah.
Vivek, I have a couple of questions. One is just in tune with what Shubhro has just now said. If you do a dual chamber pacing, you are taking the septum away from the LVOT. Now, if you synchronize it, LV first, in that case, the same problem is going to arise. The LVOT obstruction is going to arise. That is one. Secondly, what about burnt out phase HCM, which is having LBB?
So exactly, sir. That is what I said. Classically,
CRT is not indicated. Can you explain why? I am talking about a burnt out phase. I am not talking about a hypercontractile ventricle, which is going to create obstruction. I am talking about a burnt out phase where the heart itself is dilated. You have seen a patients in our ward. The patient didn't have an LBBB, but we put in a ICD there. This type of patients who are having a dilated heart. What about what's wrong if we give CRT in patients who fulfills the indication of CRT in heart failure?
Yeah, mechanistically, sir, I don't know much, but again, sir, in CRT in burnt out phase of HCM also the response to CRT is not very good.
Why? That's what I'm asking. One is myocardial part. Myocardial part is not going to improve much. But if there is an LBBB, it is going to have some asynchrony. And here, at this point of time, we are not much bothered about the LVOT obstruction because it's already dilated. Heart is dilated. Say, end diastolic volume is in the tune of 58 to 60. And there is hardly any obstruction at that point of time.
In fact, that is why the recommendation is single chamber CRT in case of heart failure, because single chamber will take care of the LVOT. This desynchronization comes as a favorite point.
Can I just answer if possible?
Yeah, sure.
Yeah. So actually, what sir is telling that why it is not.
Shuchit, please unmask. Open up
Yeah.
the, please open the video.
No, that's okay. So,
Unmask yourself.
yeah. So what I was telling is that this LBB, often HCM comes with an IVCD, not an LBB. That is the first thing I feel.
No, that is always, yeah.
Second is that usually the delay in this LBB or IVCD is at a myocardial level, not at the level of the conduction system or below. So this delay is mostly due to scar formation in the muscle. So if you do an MRI of those patients, there will be extensive scarring. So in those patients, if they have a significant area of scar, then CRT is usually not going to help in those patients, but we can try. My idea is that.
Shuchit, I will ask a question back. In patients with dilated cardiomyopathy, with LBBB, very often we find a septal Q, very small septal Q. These are basically, these are myocardial blocks rather than a conduction system block. But we do CRT there.
Yeah.
So what's wrong if we do it here?
No. So basically here the scar is, I think the scar will be more, number one, I think so, because there has been a burnt out phase. And in those cases, what you are telling, sometimes the response of CRT is lesser if that is due to myocardial disease. So often we do a conduction system pacing along with the CRT in those cases of non-ischemic cardiomyopathy, which gives a better result than only CRT.
So you can say the expected result won't be very good. It will be less than optimal, but it should
septal scarring is also more in HCM, I think, because that is one of the reasons.
I have some reservation in that statement that CRT should not be done in patients.
No, should not be done. I think that is not correct.
This part I have a little reservation.
What is the conclusion? What is the conclusion? Is it single chamber CRTD or double chamber CRTD?
CRT we are thinking of, so definitely CRTD we are thinking of, definitely.
No, sorry,
but
ICD. If you have ICD and CRTD, there is definite evidence of desynchrony. So obviously we go for the CRTD.
Yeah, because we don't have any other option, and CRTD response will be less, but I think that can be tried.
Now, if you, Shuchita, if you are given option of single chamber, double chamber, I feel it is better to go for a double chamber ICD. If you are actually implanting an ICD.
No, the question was here whether we go for CRT or not that ICD.
Dr. Dotto, what he is asking, single or double chamber, what is the recommendation? For example, if the patient is having indication for ICD for primary prevention, only for primary prevention, it's not secondary prevention. So is it a single chamber ICD or a double chamber ICD you are actually planning?
So conduction system disease is there or not? That is the most important thing.
I think probably a dual chamber may be better because this patient might
if you have a Brady indication associated, dual chamber is better.
This patient
another reason why dual chamber is better, because this might have a role to prevent atrial fibrillation. Dual chamber ICD.
That is debatable. That is debatable.
I say doubt.
Its detection of atrial fibrillation would be better.
Yes, that is also doubtful. That is also doubtful, sir.
Fibrillation they won't be able to detect with the atrial lead.
No, that is okay. But irregularity, there are some algorithms which can detect, and that has been shown to be equal almost.
We must come to a conclusion about what should be our approach in a patient of burnt out ICH, burnt out hypertrophic cardiomyopathy, where the patient requires some assistance in the form of pacing. Now, because of its burnt out, we don't expect anything better from the LVOT region. So in these situations, I think ICD dual chamber should be good enough. Maybe we don't go for CRTD.
Say if the QRS is wide, we do have option of CRT as well.
Yeah, that's exactly what I also think. If there is an otherwise the patient fulfills the criteria for a CRT, in that case, one can go for CRT, but in this case, perhaps CRT-D will be preferred.
Yes. Okay, but CRT will try to reduce the LVOT and LV contraction time, or is going to reduce
That is exactly
LVRV time.
what I was telling, that this is a dilated heart. This is a dilated heart, and I'm not too much bothered about the LVOT obstruction here. So that's why perhaps a CRT, though what Ovik and others have said, that this is not going to be as beneficial as
the benefit of CRT will not be that much, but if there is a classical indication of CRT in the burnt out phase, probably CRT should be done.
Given. Yeah.
And in that situation, I think CRT-D is a better option than plain CRT.
Exactly.
I have one question.
Yes, sir.
That is, I come across one patient of HCM that is already a dual chamber ICD in place. But the problem is LVOT gradient is not much, around 50 to 55, but RVOT gradient is more than 100 there. And patient is suffering from right heart failure rather than having respiratory distress kind of thing. So what is, the management kind of thing in here? RVOT is hugely thickened that part and producing gradient more than 100. So what to do?
Yes, valvular PS is not there.
Valvular PS is not there. No valvular PS. And RVOT is very much surprising because everywhere, lots of echocardiographies are there. Patient is having lots of
MRI has been done.
No MRI. Patient, ICD was done in SSKM hospital. MRI.
How did you confirm the HCM?
HCM is the echocardiography. HCM is there. LVOT gradient.
Surgical myomectomy is an option. Surgical myomectomy is an option in this.
Yeah, exactly. That is what I was about to say. That in this group, sorry.
Patient doesn't have any RV dysfunction. This definitely patient will having RV dysfunction. Otherwise, patient will not.
But more than 100 gradient.
100 gradient is basically a sort of severe subvalvular PS. It's also, it's almost like that.
Whatever be the treatment, we should remember that this patient is going to be going to have sudden arrhythmogenic cardiac death. Possibility is very high.
Exactly.
So we should at least have an ICD either.
He is already
ICD. Yes.
But if the patient is symptomatic, probably a myectomy is the only option.
Yeah. How about the symptoms, Shumanta?
Yes, sir.
How is the symptoms?
So symptoms are vague. Patient cannot walk. Maybe patient just half landing. Patient can go to half landing.
That means at least class 2 to 3 symptomatic.
Class 2 to 3.
That situation.
If the patient is class 2 to 3 symptomatic, despite treatment, I think surgery is
surgical myectomy is the only option in this patient.
On top of it, and on top of it, as Anyanda has said, these are the patients who require who has a high propensity of having a sudden cardiac death. So you can go ahead with an ICD as well.
The surgical myectomy of RV dysfunction, no?
Sorry.
Surgical myectomy of RVOT to relieve the RVOT obstruction. There is a patient will develop frank RV dysfunction.
Why?
Not necessarily.
No.
Not necessarily.
How far you will go?
This is
how far you will go?
If the RV dysfunction in this case is perhaps because of the obstruction per se, so because of the pressure overload. So if you can relieve the pressure overload, obviously the patient is likely to improve.
This is a simple surgery similar to subvalvular PS.
Subvalvular PS.
Similar to subvalvular PS, you need to just relieve the obstruction, and there is nothing going to happen with the RV function, because if the RVOT obstruction is gone, then RV function will improve. It is not going to.
Okay, and LVOT, the same setting LVOT,
if the patient is having surgery, it is better to go for both, because always the surgical myomectomy is an option when the patient is having some other surgical indication. Fine. So if the patient is undergoing bypass surgery, aortic valve replacement, it is better to go for the surgical myomectomy. So similarly in this case, because the patient is undergoing RVOT.
And what is the age of the patient?
65.
65 is of course another part, because myomectomy does very well in a younger age group.
So
But sir, in this patient, probably there is no other option.
No
left.
other option, perhaps.
Yeah.
Yeah.
And
Yeah.
Any medicine,
here. That's the problem. Huh? CTVS surgeon is not, I mean, not very much eager to do RV, I mean, myomectomy here. He is telling that is a bad surgical candidate. I'm telling you, that's the problem. Bad surgical.
Send the patient to a center where they do this type of surgeries more. In a high volume center for hypertrophic cardiomyopathy, unless and until you send the patient or get the patient get operated there, results are not good. If you do once in 3 years,
It's
your
also
result won't
written
be
in
good.
the recommendations also. It should be done in the high
In a
volume
high
centers.
volume center, other than where it's frequently done. Otherwise, the results are not going to be good. It is already 10. I think every good thing should come to an end. Let us conclude it today. Thank you, Shumanta and Ovek. Thank you very much.
Thank you, sir.
For this
Thank you, sir.
wonderful cases. One Shumanta presented a wonderful case which we couldn't solve. And Ovek gave a very extensive review of hypertrophic cardiomyopathy, and on top of it, the other participants added up some queries which made the discussion more lively. Thank you very much. We will be meeting again after 2 weeks on Sundays at the same time. You will get the information. This time I will try to send it both by WhatsApp as well as by email. I will collect the email ID of all the participants and all the group members, and I'll send it by email as well. And till then, good night, stay safe, and have a nice time. Have a nice time.
Good night, sir. Good night.
Good night. One announcement is, if the COVID scenario improves, as it is likely to, in that case, we will be having one such sessions in person once in, say, 2 to 3 months. Rest everything will be in online, but at least once in 2 to 3 months we'll try to meet in some places if the COVID scenario improves and we get the permission. Thank you, and good night. Good night, everybody.
Good night.
Good night, everybody.